Hi, everyone, and welcome to this new episode of the prestigious Global P.A.D. Impact Awards, brought to you by the Global P.A.D. Association, where we are honoring the recipients of the Global Vascular Research Team of the Year Award. This accolade is dedicated to physicians whose pioneering research is transforming patient care and outcomes for those suffering from peripheral artery disease, or P.A.D. Today, we celebrate the exceptional achievements of distinguished individuals for their groundbreaking work in conducting the LIFE-BTK trial. Their work with drug-eluting reabsorbable scaffolds offers new hope for improving the quality of life for PAD patients. So please join me in giving a big congratulations to these researchers and welcome Dr. Ramon Varcoe from Australia, Sydney, Australia, to receive the award on behalf of all of the researchers on the team. Welcome and congratulations.
Thanks, Kim. Thanks for having me.
Of course, we are so glad that you could join us. You're joining us from Australia, 9 o'clock in the morning there. It is 4 o'clock in the afternoon here in California. Your coffee, my mocktail.
Yeah. Hope
Well,
you're
we
enjoying
really,
yours.
yeah. So, how does it feel to be recognized with the Global Vascular Research Team of the Year Award?
It feels fantastic. I mean, you sort of alluded to the fact that research is a tough game. There's a lot of work that goes into it.
Yeah.
I'm here representing the management team, the three principal investigators, but there's also a whole team that's working in the background of statisticians and clinical trials people and people on the coalface as well that have all contributed greatly to a trial like this. If you can imagine an RCT as meaningful as LIFE-BTK, the preparation started 5 years ago, maybe even a bit longer ago, and we've been working intensively over that period. So it's great to get that sort of recognition that you're offering here, and we couldn't be happier with the published results and the results that are to follow, which should be coming out pretty soon.
Yeah. Can you talk about the trial that you conducted and its impact on PAD treatment?
Yep, sure. So you'd be aware that below the knee or infrapopliteal arterial disease is a really tough thing to crack.
Yeah.
These are small arteries, they're heavily diseased, heavily calcified often, and angioplasty, which has been around since the 50s, has really been the mainstay of treatment for some time. So if we reflect on that, we've looked at a number of devices below the knee that just haven't seemed to perform as we would have hoped that they would against angioplasty. A lot of RCTs have failed. And then LIFE-BTK comes along, and it's been the first successful, large-scale, rigorously conducted RCT in this space with a hugely positive result. So we couldn't be happier, for the trial team, but more importantly for patients that are going to get access to this device and the physicians out there that will have a new tool to use to save more limbs around the world.
So talk a little bit more about the bioabsorbable scaffolding.
Okay, well, it's a scaffold that's made out of a polymer called PLLA, and it also has a resorbable polymer on its surface, which contains a drug called everolimus. And that everolimus is an anti-proliferative drug that stops neointimal hyperplasia forming, so prevents
The scar
restenosis.
tissue. Yeah.
Yeah, which has been one of the Achilles heels of just simple angioplasty procedures. They tend to narrow down through that scar tissue over time. So the drug prevents that. The scaffold itself creates a mechanical property that holds the artery open for a year to 2 years. So that's really as long as you need. And then it disappears completely. So once it's done its job, it disappears from the body in a very gentle process, and then it leaves nothing behind. So that's great if you're a surgeon, because if you need to come back and operate on arteries, metal stents can really get in the way and make open surgery quite hazardous. So this is a way of repairing the vessel, stopping it re-narrowing, and leaving all options open for the future if the patient does need surgery.
I think that that's a really big point of contention for so many surgeons in that when there are a lot of the bare metal stents that are used, they don't leave much room for a landing zone. So in case endovascular or minimally invasive procedures with wires and balloons and things like that. In case that fails, at least you would still have the option for an open surgery as a last ditch effort to save a limb.
Yeah, exactly. That's been the issue for a lot of surgeons. They haven't liked the idea of placing metal stents into this area for
Mhm.
fear of eliminating future treatment options. So this hopefully will alleviate those fears and have a stent available for patients in the future, which is going to perform a lot better than angioplasty.
And why do these areas, we get a lot of questions all the time because we always say that, hey, if you're going to have a procedure anywhere in the leg, really try to make sure that your doctor takes a less is more approach and leave nothing behind if possible. And they always say, well, what does that mean? Why can't we, why don't you want to put stents? Even in the thigh, why don't you want to put stents when they do so well in the heart? What is it about the legs that makes stents not as durable in the legs as they are in the heart, regular bare metal stents?
Well, it's a very different environment, the arteries of the leg compared to the coronary arteries. There are a lot of stresses, as you can imagine, when you bend your knee and hip. That puts that artery into all sorts of positions, flexion, extension, torsion, even compression. So these stents are copying a pounding as we walk around, as we conduct our activities of daily living. So it's a very hazardous environment for a metal structure, which tends to fracture and deteriorate over time. That's been one of the issues. And the other issue is it tends to act as a chronic irritant. Bare metal stents without drug on them tend to incite this neo-intimal hyperplasia, or scar tissue, as you called it before, which leads to ongoing narrowing. And then once you've got that narrowing inside a stent, it's a very difficult situation. We don't have a great type of treatment for that in-stent restenosis. So we go into sort of a downward spiral where patients often do very badly over time.
Why is it that some patients do really well with the drug-coated balloons as a type of treatment for in-stent restenosis versus other patients that it just doesn't seem to last as long? I know that's a loaded question, but we do get asked that all the time as well.
People don't really understand what leads one patient to develop intimal hyperplasia and not another. So it is a scar tissue response. And I think of it as a bit like if you were to have a laceration on your skin. Some people have minimal scarring and other people have an overactive scar, like a keloid scar. The same thing is true of the arteries. You have a different response in those arteries. And some people, we can put a stent in and they'll do fine. And 20 years later, it's still going strong. But the vast majority of patients will have issues down the track because of this chronic irritation of the metal structure. So something that disappears, theoretically, has a lot less likelihood of developing late and long-term complications.
And is that because there's also a drug on there as well, with these bioabsorbable stents, the scaffoldings?
It's
So it's
definitely
like,
partly about the drug,
okay,
but
gotcha. Oh,
there's more to it.
go ahead.
There's more to it because you need that mechanical scaffolding to overcome the calcium and the recoil that tends to
Right.
happen in these heavily diseased arteries.
So what are the key findings of this entire study and how do they advance the current treatment protocols for PAD or have the potential to actually advance current treatment protocols for PAD?
Well, the key findings were the primary efficacy endpoint, which was a composite endpoint, went was 30% better in the Esprit arm of the trial, which was the drug-eluting resorbable scaffold arm, compared to angioplasty. So 30% better at 12 months is an extraordinary number in this space. What it means is you only have to treat 4 patients to have one one advantageous outcome with an Esprit scaffold compared to angioplasty. So that's pretty amazing. We haven't really seen this in BTK trials before.
So what were some of the
What does that
biggest
mean?
challenges? I'm sorry.
And what does that mean for the algorithm? Well, I think it was the second part of your question.
Mhm.
So we're still trying to work out the algorithm, because in truth, we tend to find very long lesions in tibial arteries. And at the moment, the scaffolds only come in lengths up to 38 millimeters. So we're trying to work out how we're going to treat those long lesions. And there is future developments coming through, which will have longer scaffolds, which will be more applicable to that everyday common garden variety disease that we see. And there are other questions as well, like whether you use it as a bailout or a primary therapy. I have very firm views on this, that it should be primary therapy, that you should be aiming for total lesion coverage if you're going to get the best results like we did in the trial. And then there's issues around bifurcations. We're not really sure how it's going to go around those. But this is really exciting time because we're finding out all these things as we do more and more research into how scaffolds are best used and what that algorithm might look like.
When it comes to these research, everyone likes to have an opinion. So I'm curious on the feedback, and any naysayers along the journey in bringing this public.
There's always people who are reticent to adopt technologies early. They've got their concerns and they're slower to adopt, and that's fine. I mean, one of the criticisms is, like I said before, we're not really sure how it's going to perform in the real world disease, the long lesions, the bifurcation lesions. But this is a starting point, as I see it. This is a proof of concept. We know this scaffold is better than angioplasty now. The trick is to now turn it into an everyday tool that we can use for all the patterns of disease we see, not just a few.
Is the price right?
Well, interestingly, it hasn't come to Australia yet. It's not approved,
Well,
although it
that's
is in
what
the
I
United
mean.
States.
Is I know that a lot of folks try, you have a lot of trouble getting a lot of these newer devices there in Australia. So, and it has a lot to do with the pricing and the adoption and the volume of cases. And so I'm curious, you must be dying to get your hands on it then. And will the price be
Yeah,
right?
I've been using it as part of the clinical trial, and before that, I was using the predicate device, which was the absorbed coronary scaffold, since 2012. So I've really been using it in my patients for 12 years now. Um,
Wow.
and we've had great results over that time. And now we're trialing newer scaffolds as well. And so I still have access to them as part of clinical trials in my institution. But you're right, most hospitals in Australia don't have access to this device or future new generation devices. So it will be great once we do get approval through our local regulatory system, which I'm told may be early next year.
And we have a question that's coming in, and Anne wants to know, how can you use a coronary stent in the leg?
How can you use it? Well, it's
You know what
similar
I mean?
size.
Yeah,
Coronary stents are similar size in
right.
terms of the diameter. Um, like I said, we could use longer ones because of our longer patterns of disease, but you can use multiple of them. A lot of this interest came from having really good results using
Mhm.
coronary metal stents in the legs. Um, there have been multiple randomized controlled trials that show that they work pretty well, and they've been used off-label for some years. So it's
Yeah.
quite easy to adapt and put them into the legs. And it may well be that they work better in the legs, certainly absorb the coronary scaffold that came before a spree worked better in the legs than it did in the heart to some extent. So you can easily adapt it, and it may just be that the legs are the most receptive arteries in the body to
Yeah.
apply these scaffolds.
It's interesting. That's exactly what she says. Yes, when it comes to the how do you use it off label, but it is once a device is actually approved or cleared, then it can be up to the discretion of the physician to adapt it for other uses as well. So what were some of the biggest challenges you faced during this trial? We talked before we got started here just about how challenging and the time, the resources that go into putting together a trial. And then on top of that, your general clinic, how do you overcome some of these challenges and also balance your time?
Yeah, it's hard actually. And it's particularly hard because I'm in a different time zone to the whole team. The other PIs are on the East Coast. A lot of the Abbott folks and the other team that were involved are on the West Coast. So getting the time zones right took a lot of effort. But that's just logistics, really. I think, the biggest thing was, and I don't want to get too bogged down into the detail on this, but the biggest thing was getting the primary endpoint right, because we had to design a new primary endpoint. And we did this based on our theory that the failed trials that had come before this one, we didn't think that necessarily those devices didn't work. We thought it was more likely that the trial design had chosen the wrong endpoint. So we went to a great deal of effort to explore what the right endpoint might be. And we chose this composite made up of 4 different components. And I think it is the right endpoint for BTK studies. And I'm hopeful it will act as a blueprint for all BTK studies that come afterward.
And where did you draw the line in terms of the types of patients that you were considering for this trial, that you enrolled in this trial? I assume that because they were BTK, you had a lot of diabetics, a lot of chronic kidney disease patients, and the like. Is
Yeah,
there
well,
anyone left out of the trial that you would maybe the next time include in the trial?
there's always exclusion criteria. That's important to do with any trial. This was a real world group of patients with chronic limb-threatening ischemia, though. So they had the comorbidities you would expect, high proportions of things like diabetes,
Yeah.
chronic renal impairment, hypertension, dyslipidemia, tobacco use. So it was really real world. We also had a high proportion of females, and we had a high proportion of racially diverse patients in the cohort as well, which we worked really hard to achieve, and we were quite proud of having a really representative racial group across the cohort of the study.
And we have a live studio audience of patients. And so I want to turn the mic over to Heinz. Heinz, go ahead and unmute and ask Dr. Varcoe your question.
What is the approval process for stuff like that, like what you went through? How long does that take? Is that years and years, or is it months and months?
Well, regulatory approval in the United States happened quite quickly for us after we published the results. We'd been working solidly with FDA all the way through the process, so they were well informed as to how the trial was progressing, and I think that was helpful. And then we sat down with them and did a deep dive into the data once we had access to it, once it was all locked away and had been analyzed. But then once the trial was published, they go through their due diligence process. I'm thinking it probably took about 3 or 4 months from memory. And then it was available in the US, which was, I thought, pretty swift.
Okay.
Each country, each region has its own regulatory process, so some of them are slower than others. But, it's coming. It's already in Hong Kong, this technology. Some other parts of Asia are getting access to it. We're hoping that Europe will have access to it soon, and then maybe Japan. And as I said before, I think Australia maybe early next year.
And when you were going into this trial, you had to have known that this had the potential to be truly groundbreaking for the treatment of these CLI patients.
Yeah, well, I'd been in the luxurious position of having had access to the absorb predicate. So I'd seen how well these polymer-based resorbing scaffolds could work in our single center experience. And there were a couple of other centers that also had access, one in Singapore and one in Chicago. So our data from the 3 centers was really similar. So I'd seen over and over that this device was going to be effective. When you see it with your own eyes in your own patients, it gives you a great deal of confidence to know that when you do go through the trial process, it's likely to fall in favor of this new technology.
What's next for you in terms of research? Where do your interests lie? What do you want to participate in or create?
Well, first up, the LIFE-BTK trial's got a lot more to give to the scientific community. So we are about to present 24-month data at the Viva conference in November. There will be an economic analysis presented at the TCT meeting in October and then again at VEITH in November. And there's also an anatomical breakdown using the GLASS criteria that is going to be presented at Viva as well, and also some information on diversity, equity, and inclusion at that same meeting. So there's lots coming down the pipeline from that trial, and there's going to be more to come after that. So that's really exciting to be part of all of those projects. The economic analysis, I think, is a very important piece of work that I've been heading up. because at the end of the day, the health system has limitations and we have to make sure it's viable economically.
And that definitely was part of my question in terms of the pricing, the affordability of it, and that does help drive adoption, around the world. And I think that that's really important. So I can't wait to hear just the economic benefits of it, because that, I think, is going to play a critical role in us being able to see it, especially in Australia, especially the rural areas of Australia, and then also the rural areas of the United States and other parts of the world as well. I'm curious though, a little bit, I want to get a little bit personal. I want you to share just a little bit about your career journey and what triggered you to actually specialize in not just PAD, but critical limb ischemia especially. It's a very niche area.
Well, I guess I was inspired to be a vascular surgeon because I still love big open surgery on blood vessels. It's quite exciting stuff. But as I got into it, in Australia, we don't have large quaternary centres that just do aortic aneurysms, for example, or just do carotid disease. All of the centres in Australia do everything. And when I was contemplating where my future might lead, what I saw was a real change, a sea change of patients who used to have amputations now not having to have them anymore. We rarely do amputations in our centre anymore. And I thought that would be an exciting area to really sink my teeth into and specialize in. And the more I did that, the more I learned, the better I got at treating patients with CLTI. The more I realized that we needed to know more, and that drives the research. When you have a lot of questions in a particular space, then you want to answer them, and that's where the research comes in. So right from the very beginning, I've had an inquisitive mind. I've tried to ask those questions, and when we didn't have answers, I've tried to answer them through my own research, and now working with some sponsored research for big RCTs.
Was there a certain pivotal moment in your career? We call a special series that we do the 6 minutes that mattered in your career. Some sort of spark that led you in a specific direction. It might have been a patient, a conversation with someone, a clip from a movie, a documentary, someone on the podium. What was that one moment that truly mattered in your career?
I guess initially it was being inspired by mentors. Some of the vascular surgeons that I trained under in the early days were larger than life characters that really enjoyed what they did and made it fun and interesting. And it was always challenging. Vascular surgeons always challenging. So I like a challenge. And then some of my other mentors were academics, and they taught me the value in scientific methodology and how to ask questions as you go through and try to answer them, because surgery has traditionally had a lot of doctrine associated with it. People just often do things because it's always been done that way. But that's not my nature, just to do things because they've always been done that way. I always try to get to the truth and try to answer those questions when they crop up.
In choosing critical limb ischemia, was there a moment with one particular patient? I know you're going to say, oh, yes, with so many of them, but I want one story that truly reaffirmed your choice to do advanced limb salvage and critical limb ischemia, that one patient that still stands out. For example, we had Craig Walker that came on recently, and he has a top limb preservation program here in the United States, and he got an award for that. And he was saying he will always remember that one patient that came in a wheelchair, and then in the follow-up came in dancing. And so I know you must have one at the very least that you can share their story.
Yeah, well, I get a lot of secondary referrals. So patients with critical limb ischemia are often at the end of their tether. They've been told they need an amputation, and they come to me for a second opinion. So one that springs to mind is a patient who had been treated in another hospital in the western parts of Sydney and had been told that their leg was unsalvageable. And he had end-stage kidney disease and he was on dialysis. So these are the toughest patients to treat. But he came to see me, and I said to him, like I say to all of them, it's a long journey. The easiest thing to do is just to cut your leg off. But if you don't want an amputation and you're prepared to go through the journey with me, I'm happy to work hard and save it. And we worked hard together. It took multiple procedures and it took multiple debridements and plastic surgery of the foot, and of course the revascularizations, which is the part that I mostly was able to achieve. But you know, he comes to see me frequently, and he's a great guy. His father has the same name as me, so he knew I was the guy for him right from the beginning. Um, and his legs finally healed after about 7 or 8 months of trying.
Those chronic kidney disease patients are so tough. Where do you draw the line in terms of revascularization of these patients? When do you have to say when? Because they can't tolerate a lot of contrast fluid. Do you have other options such as CO2 that you use, or do you have a special technique that you use? Because we have a lot of patients that come to us and say, the doctors say it's just not safe for me as an ESRD end stage, renal disease patient to go through a revascularization.
Yeah, I don't think you necessarily need to use that much contrast. If it's below the knee disease, my technique is just to put a sheath down to the level of the knee so you can really then get good imaging with a very modest amount of contrast. I use CO2 and often just use a bit of contrast at the end to make sure we've had the desired result. But you know, when you're used to treating people with BTK disease, you don't need to do a lot of angiography. You just need enough just to see what's going on. And then a lot of it after that is just done by feel and by landmarks. Um, so I don't think contrast is a big impediment to people seeking limb salvage personally.
Oh, that's really, really good to know. And yes, he was just saying there's a question that came in from Dean, and he was asking you must use a lot of CO2.
I use it. I don't use it a lot, but I use it, yes. You need to have all those tools at your disposal if you're going to treat these really complex patients.
And what I find interesting is that you were saying, I have not had one hospital surgeon on yet that has ever told me that they rarely do amputations. So they do far less or far fewer amputations. And I'm curious the secret to your success there. Number one, are you and the system in Australia able to catch a lot of these patients um, earlier through any sort of programs, testing programs? Or is it more that your team is quick to adopt new tools and techniques for advanced limb salvage, which includes taking wires, balloons, et cetera, clear into the pedal plantar loop in the foot?
Yeah, I think it's the latter. So, you know, when I was training, I spent a lot of time in some of Europe's leading institutions, working alongside people like Andre Schmidt and Marco Manzi, and really learning those more advanced techniques right from the get-go. And then as people came through, as my fellows, my registrars, helped them to achieve those same fellowships internationally so that they could learn the same techniques. And, you know, I was teaching them as well. So we were building on that experience together. But the bottom line is, as well as the techniques, we're just very aggressive. We're happy to do repeat interventions because these percutaneous interventions are very low risk. So if you contrast that with someone losing a leg or having, say, 3 or 4 repeat interventions, most people would be happy with those interventions over a major amputation.
What sorts of tools do you use for vessel preparation? As you know, here in the United States, atherectomy is criticized quite often, and there are many universities that are telling their fellows that you should never use it at all.
Yeah, we're in a different environment to the US, as in we don't get paid for atherectomy or not very much pay for atherectomy. So there's no financial reason to use it. Um, that said, there is certainly an application for it in certain cases, just like there's an application for for intravascular shockwave.
Mm.
So we will occasionally use some orbital atherectomy down in the below the knee arteries and occasionally some IVL, but we don't use it at the same rate and regularity as what's done in the US because there isn't actually a lot of evidence to support its use, surprisingly, despite the fact that it's used almost ubiquitously around America. The evidence for its use doesn't really exist. So without evidence and it being costly for us to do, not only do we not get reimbursed for it, but we've got to pay excessively for it. It means it doesn't get used that much in Australia.
So what seems to drive you the most? Is it the patient outcomes? Is it the research breakthroughs, or is there something else that keeps you engaged in treating these critical limb ischemia patients?
It's definitely the patients. I mean, they're a desperate group of patients, often fragile and frail and vulnerable. So looking after them is a real challenge. And I like a challenge. I like a challenge in looking after patients. I like challenging procedures, and these are certainly challenging procedures. And I definitely like the research component of it because that keeps me mentally acute. Um, it's very easy just to do the same job day after day and get a little bit bored and stayed, but adding research into your practice as an interventionalist or a physician of any type is really rewarding. I'd encourage any young doctors considering going into doing a bit of research to definitely do it because I think at the end of the day, it's one of the highlights of my career so far.
So how do you envision the future of PAD treatment evolving over the next decade? Dream big, because innovation is moving at the speed of light. So I think a lot is going to happen over the next decade. Any breakthroughs or trends that you foresee?
Well, definitely technology is moving fast, and you'd have to think that after LIFE-BTK's success, you'll see more technologies coming along in the BTK space. I think everyone was getting a little bit despondent with a series of failed randomized controlled trials. But now that we have a positive one and we have a blueprint for how to conduct a trial, the proper methodology, I can see an appetite coming back from major companies to start reinvesting in this space again. So I'm hopeful it will lead to much more technology available to us. I know there'll be much more bioresorbable technology available to us. It's already coming in a series of other trials. So hopefully we get more tools at our disposal, and that's really going to change the lives of these difficult patients.
Definitely. Okay. So a couple more questions for you as part of our a couple of our series that we have. One is called Journey to Diagnosis. And I want you to just share one case that had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with this patient. Maybe it's a patient that had a spinal fusion and that didn't resolve the pain the patient was in. So why did they do that and not do a vascular assessment? Because it's been textbook P.A.D all the time.
You frequently get that scenario. Patients are often coming in having been misdiagnosed as degenerative lumbar spine disease when the whole time it has been blocked arteries. And it's because it's not all that easy to discern the two, even for experienced physicians to know how to tease out the difference. So I don't blame people for misdiagnosis there. Often when I get faced with that situation where they have both lumbar disease and blocked arteries, and I may not know exactly which is the type of pathology that's causing the pain, I'll often just treat the blocked arteries with the rationale that it's a fairly easy endovascular procedure to unblock arteries. It's minimally invasive, low risk, and it will give us an answer one way or the other as to what is causing their pain. And then, of course, having good perfusion in your legs is never a bad thing. So that's the reason I often treat their arteries first and then refer them to a spinal surgeon if required.
And for you and for the surgeons in Australia, I assume you follow standard protocols, which is you treat when there's lifestyle limiting claudication or, but preferably it's more if there's rest pain and or a wound that won't heal.
Yeah, so certainly CLI patients all are considered for revascularization and would only be the ones that are too frail that would not go down that path.
Right.
And when it comes to claudicants, yes, they need to have significant lifestyle limiting claudication. Otherwise, we sometimes use exercise therapy. We don't often use medications because they're not all that effective and they're quite expensive here. But we do work closely with some university scientists who offer a supervised exercise program, which can sometimes be really useful.
Yeah, I had one of our patients from Australia actually tell me that they had to stop their cilostazol because they could no longer have access to it in Australia, and that was very frustrating. He told us, he said it was working. What am I supposed to do? And he said his doctor told him to take ginger instead because that's a vasodilator. But that's the only option that he had. So it must be very frustrating for you with that access issue.
Yeah, the access and the cost as well. So patients have to pay out of pocket quite a bit for drugs
Yeah.
like this, cilostazol.
So, my final question to you is I want you to share a case with a big lesson for you and for others. So, describe the patient, the frustration with the particular case, and the lesson that you learned and others can learn from it. Imagine your peers watching this and wanting to learn something from you about a case that was either a success or a failure, either one.
I had a young woman in her 50s whose brother had lost a limb, had a major amputation in the past, and she really, really didn't want this to happen to her. She again came from another hospital. She'd had multiple procedures, some open surgical procedures, a lot of endo procedures. She'd gotten to that point where she had far advanced gangrene of the foot up into the calf, all the way up almost to the knee. And I treated her with deep venous arterialization, and it went well in terms of the DVA, but it was a long road for her. You know, lots of debridements, lots of skin grafts, different tissue matrices we used. But after 9 months, we finally got her healed, and she's now doing really well. I'd have to show you some pictures someday just to really emphasize how far gone she was. People just looked at this leg and went, that's unsalvageable. But I mean, the lesson I took from that was there are very few things that are completely unsalvageable. And I think it's worth having a try, particularly young people who know what they're in for, who know what the journey is all about. If they choose to have a go, and deep venous arterialization is now a new tool we have to treat these no option patients, then have a go and see if you can pull it off.
What's so amazing to me is that you can do so much with with less. I mean, being able to do so much that you're able to do in terms of limb salvage with rarely having to amputate and being able to do that with mainly a balloon and then also your genius move to use the coronary bioabsorbable below the knee, which I think probably has led to, I think you mentioned, reduced repeated interventions and
Hmm.
then the addition of some new technology, the deep vein arterialization. And are you using LimFlow or is this off the shelf?
We don't have access to lymph flow, so we use an off-the-shelf version.
Yep. I hear a
Hmm.
lot of doctors doing that as well, and it's pretty remarkable, and you're having great results.
Yeah, we're having some really good results. They're not all winners, but we're getting better and better as time goes by. There's a lot of lessons to learn. It's a new technique and there's a lot to it. But I'm pretty bullish now on deep venous arterialization, whereas I wasn't always that way. And initially, I was a bit skeptical.
It takes a little finesse, is what I hear, a lot of finesse.
Yeah, it's a lot to it, and the veins of the foot are not something that we're used to dealing with, and also the aftercare is really important in these patients. So it's patient selection, I think, is important. The trick of getting those foot veins open and getting a nice outflow is important, and then the aftercare is super important.
I just talked to a doctor this morning about a patient that we actually share. And she's that perfect person for deep vein arterialization because she has that grit, she has that fight. She can tolerate the pain because what patients sometimes don't realize, and it's good for them to know, those who are watching, that if it ever ends up where you are on deck for amputation and they do offer you the option of deep vein arterialization, you have to realize it's not for the faint of heart that it does, the wound gets worse. If you have a wound on your foot, of course, they all do. It gets worse before it gets better. It looks vicious and the pain is excruciating. But all you have to hold on to at that point is just that hope for a few weeks down the road, right? That everything's going to start getting better, things are going to start healing, the pain will start dissipating, and you're going to be back on your feet to grow those collateral vessels.
Yeah, well said. It's a difficult journey for them, but if they're up for the challenge, then it can save a leg, whereas it would otherwise be unsalvageable.
Fantastic. Thank you so much, Dr. Ramon Varcoe. We really appreciate all you are doing to save life and limb through your research around the world.